I will talk about, does mind matter in cancer? I'm a psychiatrist. I have been working in oncology for the last 12 years or so. And what we would cover today is, why is mental health important in cancer? Understanding acute psychiatric presentations. Is there anything to do with mind and cancer pain? And staff mental health. I think that's very crucial. So over the next 20-25 minutes, we will talk about that. Now, I stay in Kolkata, and if I had put in Google, I saw that I could reach Phnom Penh in 75 hours of driving, little detour over the north of India, and then through Myanmar and Thailand, and there are only 2 countries between us and you. However, life is not that straightforward, isn't it? So there are forests, there are international borders, there might be countries who might not want me to come in without a visa, the weather might be difficult, and there could be all sorts of, it might be expensive, travel, I need a car, I need a driving license, which is valid in all these countries. And like that, even though Google says 75 hours, it's not always as straightforward for a cancer patient as well. So we did a study funded by the Wellcome Trust and King's College London about access and disruptions to cancer care in India, and affordability, which is very crucial in many of the low and middle income countries. In the next 20-25 minutes, I'll cover mainly the psychological aspects of this journey. However, there is an actual physical journey as well, which the patient has to reach the cancer center. Would touch upon that, the stigma of cancer, how it affects patients. There is the decision making, because patients often rely on their family members. I was talking as I was mentioning in my earlier talk, and the economic impact and modifiers of this journey. Now, why is emotions and behaviors relevant at all in cancer care? Certain cancers start with a behavior. So tobacco smoking is not unusual in this part of the globe, and that could be one of the key causes of common cancers in LMICs. Cancer screening programs, we have seen that there is data from parts of Western India that even if you have a free cancer cervical screening program, it will be well attended, but you might miss 87% of the women with the highest risk of developing cervical cancer, which could be poverty, which could be multiple sexual partners and all sorts of social disadvantages. So you might be running a program, but you might not be able to actually always get all the people whom you would want to get at. So the fact that you have come into this room to attend the eCancer Congress today is a behavior. And you have come into this room, that behavior actually would help you to learn, and education will save lives. But had you not come in, we wouldn't have had the opportunity to interact. So I think you need to understand, when you set up cancer services, that behaviors are important. There is, of course, during the cancer treatment, often a psychiatric comorbidity. People might have depression, procedural anxiety. They might not want to be in the place where you want them to be. And the families also have a significant impact. I was talking in the morning. Rehabilitation back into normal life. Many cancers are completely curable today. Early breast cancer, many of the hematological cancers that we have heard about in the course of the day today. However, we see a lot of patients, young children who have finished their treatment, but their parents don't want to send them back to school early enough because they're scared, they're protective. So rehabilitation back to normal life, again, is a behavior, and emotions are involved. Not everybody is that lucky. There are people who are not very lucky, and you do need palliative care, as we were listening to the last talk. So end-of-life care, it's important that we look after the physical pain, but at the same time, we look after the depression and the existential issues, as was mentioned in the study earlier, where the authors had quoted Hamilton Depression Rating Scale. So emotions and behaviors are important in cancer, and that's what is the premise of this talk. Now, why do people start smoking was one of the studies we did, published in ecancer, in the ecancer journal, actually. So we asked college-going students above 18, because consent could be easily taken from adults rather than adolescents. And there were a range of responses what we got from patients, from participants. None of them were patients. And some of them felt that they would not touch tobacco because that is bad, but there were other spectrum where people thought that, I won't be able to quit. So I think, it's important that we understand the perception of the people we come across so that we're able to design interventions for them. Coming to Cambodia, if you go to the Globocan site, you see certain cancers which are more common than the others, like hepatocellular cancer, lung cancer, breast cancer, and I'll go one by one about what are the psychiatric comorbidities that might be common for each of these. Now, coming to hepatocellular cancer in Cambodia, I think the cause is complex. It's not straightforward. However, across the world, there has been some evidence saying that there could be predisposed to hepatocellular cancer because of some genetic mutation, or there could be lifestyle illnesses, or there could be hepatitis B and hepatitis C infections. In lung cancer, I don't need to emphasize about tobacco use. In depression, women who are actually getting treated for depression, it's not common for them to go through, treated for breast cancer, they're not uncommon for them to access help for treatment of depression as well. Cervical cancers, as I had mentioned, the other factors like poverty, these are social factors. Also, lack of HPV vaccination in many parts of the world. Brain tumors, I don't need to overemphasize because mind is not here, mind is in the brain, and of course, that if you have a chronic illness like diabetes, you do have a higher risk of developing psychiatric symptoms or psychiatric syndromes. But if the chronic illness involves the central nervous system, the chances of you getting psychiatric syndrome is more. So like epilepsy, migraine, similarly brain tumors, it's not unusual for them to have behavioral symptoms. Ovarian cancer is a very difficult disease, often presents in the late age with vague, non-specific symptoms of, say, GI symptoms in a 60-year-old, and people neglect. We did some research on what are the delay factors, psychosocial factors, which causes delay in meeting an oncologist in a lady diagnosed with ovarian cancer. And, of course, oral cancer, again, is associated with tobacco use. So you can see there are a plethora of behaviors and emotions which could be important. Now, coming to the epidemiology of common psychiatric diagnosis of cancer, roughly, it's a busy slide, it's around 50% of patients, have a diagnosis of depression at one point or the other, and around 50% also has increased pain. I will ask the audience to give a vote on how common is depression in Cambodian cancer patients. And, the choices are 10, 20 to 30, 40 to 50, and maybe as high as 70%. Dr. Datta has kindly agreed to translate this question. I know all of you could follow, but please.
ចាអញ្ចឹងគាត់សុំឲ្យលោកស្រីជួយឆ្លើយសំណួរគាត់មួយគាត់សួរថាតើយើងគិតថាមានអ្នកជំងឺមហារីកនៅប្រទេសកម្ពុជាប្រមាណភាគរយដែលមាន depression ចាក្នុងនោះចម្លើយ A 10% B 20ទៅ30 C 40ទៅ50 D យើងឃើញថាអាចនឹងខ្ពស់ដល់ 70% នៅលើមហារីកខ្លះ
A can put a hand up.
ចាអញ្ចឹងបើសិនជាលោកស្រីគិតថា A សូមអញ្ជើញលើកដៃ
Nobody? Okay, B.
ចាអញ្ចឹង B អូ B B អញ្ចឹង B សូមអញ្ជើញលើកដៃ1 2 3 ចា 3 for B អញ្ចឹង C 40ទៅ50អូច្រើនមែនតើ
And D?
ហើយចុះ D
Okay, that's very good. All of you have won. I will tell you, a statistics, a study published from Cambodia. Thank you, Dr. Datta. So, depression and health-related quality of life. So you can see 70% of patients with colorectal cancer, cervical cancer, breast cancer had depression. And, gastric cancer a little lower, but still 30%. So we don't have a choice of not actually addressing this. Now, psychiatric morbidity could be a coincidental morbidity. So 1 in 4 people may have depression anyway in their life, and you happen to have cancer. That's one way. It could be a reactive morbidity because, you're going through this, there is financial toxicity, effect of you losing a job, or, having other problems. So that could be reactive. As I said, there could be a CNS involvement because of brain tumor. Or there could be a general metabolic problem, which is usually transient, like delirium, which is always caused by a medical condition. And rarely it could be side effects of medications. So as a psychiatrist and as a mental health professional working in oncology, you need to look at the cause of each of the person who comes to see you. Let's think about Jai, who is 45 and has a head neck cancer. And after surgery, he cannot talk because he's intubated. His sleep is fragmented. He used to drink alcohol, which he was ashamed to share with his doctors. So maybe he's having some withdrawal. And you send a referral to a psychiatrist. So this is not an unusual situation. So we did a study on 771 patients with head and neck cancer in the perioperative period. And we found that being a woman was an independent risk factor, along with having worries prior to the surgery that I'll have pain, or worries about what will happen to my family during my treatment, or if the patient has a longer duration of stay. Again, this is in eCancer Journal, so I have sent a handout, which once we get your emails, you'll get a link to all these papers that I'm quoting. So what is depression? Depression is different from sadness in the sense that, this is a clinical syndrome. You have certain symptoms. You don't have a scan or, any other biological test which you can make to diagnose it. But the symptoms have to be persistent for around 2 weeks. It could be mild, moderate, or severe. And during depression, usually the person's functioning gets affected. So if he's a student, he could not study, or if he was working, he couldn't work as effectively. And good news is it's a curable disease and can be treated. Now, this is important in oncology because somebody might have depression and develop a breast lump and not come for a checkup because they are depressed. Or the weight loss or reduced appetite, which could happen because of the impact of cancer, but if the person also has depression, may make the person prone to more side effects for, say, radiotherapy or chemotherapy in a head and neck cancer patient undergoing CTRT. It could also lead to poor adherence to treatment with oncology, and the irritable mood, of course, impacts the family members, and the person, even after cure, might be having difficulties in getting back to normal life. Rarely, this also might lead to a completed suicide. Now, the treatment strategies for psychiatric conditions in cancer are, you need to identify these syndromes early and diagnose and treat. There are various models of lay cancer counselors versus trained mental health professionals. Sometimes you need to, of course, use medications for psychiatric conditions, antidepressants commonly. But you need to be aware of drug interactions. So say, for example, SSRIs may have an interaction with tamoxifen, which is often used for premenopausal ER-positive, PR-positive patients. And tamoxifen gets into the body as a pro-drug and gets converted into an active drug. And SSRIs inhibit that step. So you might to have a discussion with the patient that this is a situation and choose a drug appropriately, which could be, venlafaxine for this group of patients, or you might want to do psychological interventions alone. So usually treatment is time limited for depression, but it's essential that you do the treatment. Coming to anxiety, cognitive symptoms of anxiety are, you are worrying that something terrible will happen. So before the chemotherapy, you are worried that you will have vomiting. Or you could have a little stiffness of the muscles, so those are motor stiffness, or you could have palpitations, so those are autonomic symptoms. Procedures often evoke anxiety in cancer patients, so fear of injections. In head and neck cancers, again, radiotherapy, you need a mask. We have to position the patient, and that can cause claustrophobia in some patients. Having MRIs can be difficult for some patients. There are patients who actually start vomiting even before the chemotherapy is delivered. So this we consider a diagnosis of procedural anxiety. Low-dose benzodiazepines and psychological interventions can work very good. Usually treatment is successful within a short time. And you work collaboratively with the oncology team who is treating the patient. The stressful transitions, these are the transitions that actually could be stressful for the patient and the family. And I think by and large the audience here knows about them. While preventing completed suicide, I think you need to make a risk assessment. And if there is high risk, there is important that you treat the risk. So if the person has depression, you treat the depression. You bolster the social support the patient has. Tell the family members to keep a close eye on the patient while the patient is at home. And of course, in these situations, I think it would be worthwhile getting a psychiatrist to assess the patient. So assessing for comorbidities, somebody's, the socio-demographic pattern, the medical illness, psychiatric syndrome, past suicidal ideations, and level of social support. These are the 5 areas which are important when you assess suicidal risk. Now, you need to manage the underlying condition if there is a depression or anxiety, as I have said, and follow up the patient closely. It's also important that you collaborate with the family members because they would be seeing the patient all the time if the patient is at home. I'll now talk a little bit about cancer pain. And the psychological strategies for cancer pain, it could be, denial. The problems which sometimes we face is families might be often in denial and somehow feel that treating the cancer pain with medications or morphine is not acceptable because of the side effects, or worries of some families around emotions. I think pain, some people might have a very strong medical model, but if you understand the etymological roots of the word pain comes from the same word in Greek, pina, which means punishment. So often human beings throughout ages have felt that if I'm in pain, something I have done bad in the past. So it is actually a very socially and psychologically enrooted symptom. Of course, you need to give the adequate pain medications, level 1 and 2 and 3 analgesics, but at the same time, if you have some psychological support for the patient, it would help. In patients who are elderly and has dementia, they may not be able to express that they're in pain. So you might have to see, how the person is from the grimace and guess that the person might be in physical discomfort. So group and individual therapies have been tried for pain. And relaxation and anxiety management, of course, is useful. So if I give an example, say why mind and body are related in pain. So if any of you play competitive sports or have brothers or sisters who play football or something which is a contact game, you'll see while the match lasts, even if the young boy is injured, they may not actually complain of pain till the match is over. So he's not pretending, he's actually having less pain because of the pain gating and the way our brain works. So it kind of suppresses the sensation of pain. So I think if it can suppress, similarly if somebody is depressed, it can accentuate the pain sensations. Now I'll talk a little bit about ourselves as health professionals, because managing our own emotions are as important as managing the emotions of patients. Let's think about Nandini, who is 26-year-old, a nurse who is sitting, sleeping in her home. The alarm goes off at 6:30 a.m. She doesn't want to wake up. She looks at her husband, who is sleeping nearby, but thinks about her colleagues who might be sort of, expecting her to come on time, and then makes her move to get up and move to the hospital. She doesn't have time for breakfast before the car comes. She snatches a banana and some fruits, and then a piece of bread maybe, quickly eats it in the car or the van which takes her to the hospital, and goes and enters to the hospital. While she's entering, she sees the other nurse who is working her way up, who works in ICU, and she grimaces that what is she upset about, and they remember that they had both, she's a nurse who had been part of the team treating a patient who has now relapsed, and makes a gesture with her lips that this is the situation. Nandini feels bad, and somehow she puts up a smile and goes to the ward and starts working. Now that's not an unusual scenario. Nandinis would be there all over the world who are nurses, doctors, who are always working hard for cancer patients. But what happens when Nandinis get, very stressed or have burnout? So burnout, if somebody has burnout, that affects the patient care, it affects the family members and colleagues and the patient themselves. It also has associations with physical activity, drinking, low physical activity, heavy drinking, and other issues which may affect the health. So we did some study on associations of emotional exhaustion in professionals. In this slide, the circle inside shows the associations of quantitative associations. So being a woman, having increased stress of job, having work pressure, and having anxiety and depression symptoms were associated with high emotional exhaustion. As a service which looks after staff, we have done that for the past few years. And we have always said that if hospitals acknowledge that, oncology can be a very satisfying profession, but there could be times when there is a lot of stress as well. But you share the positive experiences through newsletters. If somebody has anxiety or depression, that can be identified early and treatment be provided. Don't blame yourself because the disease has come back or is having some impact on the patient. It's not personally the fault of a individual because of the outcome of a patient. So I think when we deal with several moral dilemmas, we need to remember that we are human as well. I do a lot of research, and I think having a balance between face-to-face clinical work and other clinical, academic, and research activities also would help you to become a well-rounded professional. So looking after the staff, I would say having clear job descriptions, early identification of symptoms, and having an occupational mental health approach towards relaxation and well-being will help. So I would like to conclude that developing psycho-oncology services in cancer centers, I think in a country like Cambodia would be useful definitely, given that the high morbidity of psychiatric illnesses in cancer patients published from your country. You might need organ-specific protocols for specific cancers. Please look after your colleagues. If you are not empathic to your colleagues, it's very difficult to be empathetic towards patients. And I think working as a team is essential. I would like to acknowledge all the funders for the various research projects. Many of the paintings that I've used are by an illustrator called Rajendrani, who is a psychologist and an illustrator. And with that note, I would like to end my talk. Thank you.